بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Before requesting our honorable speaker, Professor Saeed Farooq, let me tell you that Professor Afzal Javed has kindly consented to participate at 1:30 in this program, and after this program, we will have an important meeting on COFIT study, which is the international collaborative study regarding the coronavirus. So let's start with the program by Professor Saeed Farooq. Thank you.
Okay.
I ask all, please give your full attention to Professor Saeed Farooq. Thank you.
Okay. Thank you, Professor Iqbal Afridi Sahab, for giving me this opportunity to all the colleagues in Pakistan. I'm just going to share my screen so that so I'm just sharing my screen so that you can see the slides. And so basically, I'm going to talk today about the treatment adherence in schizophrenia. It's something about which I've been working for a long time now. And so hopefully you are able to see my screen now.
Yes, you can see.
Okay. So as you can see, I'm presently Professor of Psychiatry.
Sorry for interrupting you. आप इसको slide show में अगर कर लें.
हाँ ठीक है, slide show में ठीक है.
Slide show पे ऊपर slide show से भी हो सकती है, नीचे से भी हो सकती है.
हाँ मैं वो कर रहा हूँ.
F5 दबा दें, F5 कंट्रोल F5.
लेकिन मेरा ख्याल है कि वो हाँ अब हो गया. ठीक है.
नहीं हुआ. हाँ होगा. ठीक है.
Okay, so these are my disclosures. I don't go into the details, and these are the learning objectives for today. What I will try to do is I will try to update the knowledge about recent developments in improving treatment adherence in schizophrenia. And then I will try to explain the risk factors associated with non-adherence and how to complete the risk assessment in clinical practice for non-adherence. And then help you to develop the skills in tailoring the interventions for improving the treatment adherence to the clinical needs of the patient. So these are the three main intended learning objectives for the training activity today. So what is the non-adherence? First of all, I'll talk about the research evidence. What is the research evidence about the non-adherence? And then I will talk about the clinical practice, how we can improve the adherence in our clinical practice, in day-to-day clinical practice based on the research evidence. The adherence, first of all, what is the adherence? This is a definition of the adherence from a very extensive document developed by the WHO, I think way back in 2001. And the definition of the adherence is that the extent to which a person's behavior, and I would like to stress that it is the behavior of taking medication, following a diet, and or executing a lifestyle changes that corresponds with the agreed recommendation from a healthcare provider. So I think there are two things what you need to understand is that first of all, the adherence doesn't mean just adherence to the medication. What we physicians or psychiatrists would like to think that it's only the adherence with the medication. It's basically with all the advice given by the physician. The other thing important to understand is that in the definition itself, you will see its behavior, as you know very well as a clinician. So basically, like any other behavior, it's influenced by the principles of the behavior And most of the interventions related to improving the treatment adherence relate to improving the behaviors of taking medication, making things acceptable to the patient. What is the evidence of the effects of non-adherence in schizophrenia? If you see, we as a physician, we as a psychiatrist are very familiar with the behavior of the non-adherence. We see in our clinical practice every day that the patient is not taking medication for a week or so, and then they tend to relapse. And what is not very often realized, that even taking medication for a small gap, for even for few days, can have very long-term effects. And this is a very interesting study. It's a relatively old study now, 2004 in America. And what they did is that they looked at a very large population in people who filled the pharmacy, refills. Like, in America, UK, what tends to happen is that when your medicine is finished, you go to the pharmacy and they refill the prescription. And what they did, it's not a very, demanding study. What they did is that they compared the rates of those who filled the medication regularly, what was the relapse rate in those, and compared to those who were not able to fill the medication regularly. So say, for example, if a patient had his medicine finished at 31st of August, and then they finished it they came to take it at 5th of August. So that is 5 days gap, then another after 1 month. So they compared all of them. And what they showed, and that has been shown by number of other studies, is that a gap as small as 1 to 10 days without medication over a year period was associated with increased risk of hospitalization with an odd ratio of 1.98. So almost twice. So simply speaking, if patient has not been taking medication for 1 to 10 days over a year period, as a group, that group of people had a risk of relapse almost twice compared to those who didn't miss the medication for a single day, simply speaking. So even, even missing the medication for a few days, of course, then there will be other risk factors, coming into play as well. But even missing the medication for 1 to 10 days in people with established schizophrenia, the risk of relapse or risk of hospitalization increases almost twice. So that means that we need to take the treatment adherence very seriously in our clinical practice. So how we can help our patients to improve the treatment adherence? The research evidence can be classified into 3 broad categories. The interventions, the treatments or therapies to improve the treatment adherence can be broadly classified into 3 categories. One is what I call psychosocial interventions, the pharmacological interventions, and then increasingly these days, the digital interventions. The psychosocial interventions can be classified broadly, and this is a very broad category. I'm trying to just give you an overview. These can be broadly classified into psychoeducation, compliance therapy, family intervention, CBT for treatment adherence, and interestingly, even the financial incentives. And I will just give you overview of these psychosocial interventions just to give you a flavor of what's happening with the psychosocial interventions. Of course, this demands another 1-hour lecture in itself, what psychosocial interventions for treatment non-adherence are, how they work, etc. So basically, if you see overall evidence, and that has been nicely summarized in one of the systematic review published in American Journal of Psychiatry a few years back. And what this systematic review showed very interestingly is that interventions that if you are doing the interventions to improve the treatment adherence, they have to specifically address the treatment adherence. So interventions such as family education, they improve the family education or psychoeducation, they might improve the patient's concept about the illness. What is the illness? What is the medication, etc. But it does not necessarily improve the treatment adherence. To improve the treatment adherence, the interventions have to specifically focus on medication taking behavior. The other interesting thing was that it showed that the interventions with intensive and focused approach and with smaller number of sessions were more effective than the longer interventions. So the psychosocial interventions with 8 to 10 sessions were more effective than interventions which had 10 to 18, which had, I think, 12 to 18 sessions. So basically the evidence from the psychosocial interventions as a whole shows that the interventions have to specifically, the psychological approaches have to specifically focus on medication taking behavior. Non-specific interventions, non-specific counseling, non-specific psychoeducation can help to improve other things like people concept about the illness, what this, it might decrease the stigma, etc. But it doesn't necessarily improve the treatment adherence. One of the examples of the psychosocial interventions is the CBT-based approach. And there are about, I think, 6 randomized controlled trials which have used the CBT-based approaches. They have different names. Some people call them compliance therapy, others call it adherence therapy, others specifically call it CBT for treatment adherence. What is the gist of the CBT-based approaches is that it does not insist on patient accepting a diagnosis of schizophrenia, and it does not insist on a medical model, as you can understand. Primary technique is that it focuses on what bothers the patient. Where is the patient hurting? Where is the patient suffering? And whether the patient is suffering from, I'll give you an example. So CBT-based approaches challenge the patient's cognitive processes, such as maladaptive behaviors, to a goal-oriented explicit procedures, and the adherence is conceptualized as a coping behavior. That is important to realize. So in CBT-based approach, for improving the treatment behavior, for improving the treatment adherence, the adherence is conceptualized as a coping behavior, just like a coping behavior in schizophrenia. Like, say, for example, you might have a coping behavior for coping with the auditory hallucinations or coping with anxiety, etc. So medication taking behavior is conceptualized as a coping behavior, and then the therapist tries to see the beliefs around that behavior and tries to modify them. So say, for example, what they tend to do is they tend to, what bothers you? Like, say, for example, if the patient is very much bothered because of the auditory hallucinations, they are not able to go out and mix there with their friends or go to their parents' home or go to their work. So instead of arguing about the importance of taking the medication, the therapist focuses on how the medication can help to improve the auditory hallucinations so that the person is able to go out and achieve their objective, which they are not able to do otherwise. So it's just a small example. So it's basically, it's focused on the behavior. So as I just said, I just was trying to give you just a gist of the concept. It's not possible in this brief lecture to give you an overview of the CBT-based approaches. But what I was trying to give you an idea of the approaches which have been used for improving the treatment adherence. An interesting example is the financial incentives. And I'm not going into the detail of this slide. There are 2 large trials which show that, you know, even paying the patients to accept the medication is A, helps the treatment adherence, and B, it's cost effective. You know, the small amount of money you go there, there can be ethical issues about this research, but this is published in very I think one of them is published in British Psychiatry, other is in, so these are all published papers in respected journals. So what they have shown is that the financial incentives can also improve the treatment adherence in people with chronic schizophrenia. I just included this example to give you an idea of the variety of psychosocial interventions which can improve the treatment adherence. So this was just a brief overview of the psychosocial interventions which can improve the treatment adherence. Now coming to the pharmacological interventions. Unfortunately, somehow when it comes to the pharmacological interventions for improving the treatment adherence, we always tend to think the non-adherence in schizophrenia just with the depot medication. So the simple concept is the patient is not taking the medication, just stick them a depot. No, that's not right. You can do a number of pharmacological ways, for example, selecting the drug carefully with optimum balance of therapeutic effects and side effects, minimizing the side effects, adequate dose adjustment, treating the side effects effectively. I believe one of the problems we as a psychiatrist, we are not very efficient in treating the side effects effectively. Simplifying the treatment regime, for example, just making the medication instead of BD, instead of taking twice a day, just converting all the medication into one OD or one NOPT dose, almost doubles the rates of treatment adherence. So these are the simple pharmacological ways in which you can improve the treatment adherence. And then, of course, the use of long-acting injections. Just to give you an idea of how the treatment adherence, how the side effects are important in improving the treatment adherence, I'll give you an overview of the varying side effects of the different antipsychotics. I think those trainees who are preparing for FCPS, they might have seen this Forrest plot. If not, they should. This is one of the largest meta-analysis of the antipsychotic efficacy published in Lancet. It was published in 2013. At that time, they had 212 trials. They have just published it again in 2019, and now they have included, I think, 400 plus trials. And this Forrest plot beautifully summarizes the efficacy aspect of the antipsychotics. Just to put it briefly, except the clozapine, clozapine stands out. Amongst the non-clozapine antipsychotics, there are very small differences in the efficacy. There are not very large differences in the efficacy. But what they showed is, so basically the median difference of efficacy between different antipsychotics is 0.11. But the median difference as far as the number of side effects is concerned between different antipsychotics is 0.34. So almost, the side effects different between antipsychotics, different group of antipsychotics ranging from something like lurasidone to quetiapine to clozapine is about threefold. So if one drug causes, I'm just trying to simplify, if just one drug causes 10 side effects, the other drug causes 30 side effects, or the amount of side effects with other drug could be 30 times more than the drug B. So basically what this plot shows is that a very important factor in choosing the antipsychotic which can help to improve the treatment adherence is efficacy, but more importantly, the side effects. And this plot, again taken from the same meta-analysis, shows the differences in the efficacy. Unfortunately, because of the audio-visual nature here, I won't be able to explain it completely, but I can share the slides, by the way, after the lecture. So if you can see, these are the 5 most common side effects: EPS, prolactin, QTC prolongation, sedation, and weight gain. And I'll just focus on one of the side effects of the weight gain. So you can see the dots on the middle line of no effect. Anything on the right side, when I'm seeing from my screen, on the right side of the plot of the line is greater side effects. Anything on the line itself means the side effects are comparable to the placebo. So any dots on the line itself means that this side effect in this medication is just as good or as bad as the placebo. So there were 4 antipsychotics, I would say 3 antipsychotics like haloperidol, ziprasidone, lurasidone. They had side effect weight gain comparable to the placebo. And then aripiprazole, amisulpiride. And when it comes to, you can see at the bottom of the plot, the olanzapine, zetiapine, clozapine, they had the maximum weight gain. So this plot, then you can also see the prolactin, say for example, QTC prolongation, say for example, you can see lurasidone, aripiprazole, paliperidone, haloperidol, they had the QTC prolongation equal to the placebo. But when you come to the sertindole, amisulpiride, it has the maximum effect on the QTC prolongation. So what this Forrest plot shows that and I think every clinician knows about it, that it's the side effects profile which actually distinguishes a lot of antipsychotics rather than the efficacy. So side effect and treatment adherence. So the next question you should be asking, what is the evidence of side effects interfering with the treatment adherence? I think I'm not going to the detail of this. As a clinician, you know every day that the drugs which have the maximum side effects would have one of the worst treatment adherence. And there is a good systematic review published which shows that the drugs which caused the most weight gain had what perceived as distressing, and they also impacted quality of life and contributed to the treatment non-adherence. So basically, I just leave the debate over there about the treatment adherence and the side effects. Now we will, I'll briefly talk about the long-acting injectable medications and their relationship with the treatment adherence. I think all of us realize that the long-acting injectable medications are recommended by almost all guidelines for improving the treatment adherence. And I think this is section on which the FCPS trainees would be helped most. They should focus most on it. Interestingly, and I have summarized the evidence over here, if you see the randomized controlled trial evidence, the evidence from the randomized controlled trials about the efficacy of long-acting injections in improving the treatment adherence, at best it is conflicting. There are about 4 large meta-analyses which have been published on the efficacy of long-acting injections on improving treatment adherence, and almost everyone has reached a different conclusion. And basically, say for example, one published in Lewis et al. In 2011 showed that the long-acting injection versus oral antipsychotic did improve the treatment adherence. But this is the next one, Kishimoto et al., which was a published large meta-analysis published on 21 randomized controlled trials with primary outcome measure of study-defined relapse, found that the long-acting injections were not significantly superior to the oral antipsychotics in improving the treatment adherence and the study-defined relapse. Then there is another meta-analysis. So basically, the randomized controlled evidence for the efficacy of improving treatment adherence for long-acting injection is not very convincing. But those studies which have taken not the randomized controlled approach, but which have taken the naturalistic course approach, in which what they have done is they have seen the number of relapses people had before starting the depot injection, and then the number of relapses on the medication adherence after starting the depot injection convincingly show that the treatment adherence is better in these sort of studies. So that brings the question, what is the problem? Why the randomized controlled trials do not show the efficacy, or if they show, the evidence is conflicting. It's not as convincing as you would expect from the randomized controlled trials. The evidence is not very convincing. So what could be the reason? I believe the reason lies in the design of the randomized controlled trials. I think you people should be aware, especially the trainees, that what is the design of the randomized controlled trials? What you tend to do in randomized controlled trials is you take a group of people who are not likely to adhere to the medication, and then you randomize them, half of them to depot injection and half of them to oral medication, and then you follow them up over, say, for example, 1 year period to see whether the evidence of efficacy is there or not using a standardized scale. This is a multiple choice question, and although I am not able to see and interact with you people, I think you can do it in the comments section. And I go through the questions and you can say true or false for each of these statements. That will help you to understand why the RCTs are not showing the efficacy of medication. So in the RCTs, to evaluate the effectiveness of the depot medication, short-term follow-up studies can help to evaluate the adherence. True or false? Obviously false, because for properly assessing the treatment adherence, you need to have long-term studies. The short-term studies, in the short term, usually the treatment adherence is better in any case. So most of the randomized controlled trials are short-term. They are not very long-term. Relapse prevention is not often addressed. That is another true or false. Unfortunately, again, I think you can write in your comment section, and I can perhaps see it. Relapse prevention is not often addressed in the randomized controlled trials of the long-acting injections. They usually tend to focus more on the efficacy, so they do not examine the relapse prevention. The randomized controlled trial tend to see how much the depot injection or the oral medication is able to reduce the positive and negative symptoms, not whether the patient have relapsed or not. Okay, so patients in clinical trials are more likely to have better treatment adherence with the treatment and also have better cognitive abilities. This again makes so if you imagine the procedures in a randomized controlled trial, people have to consent to the medication. People have to consent to the intervention arm. So those people who in your clinical practice are prone to relapses, they are unlikely to consent for these trials. So in a way, a very selective group of the people who are likely to have better treatment adherence are likely to consent in these trials. So as a result, if there is an efficacy difference, that wouldn't show, because in both arms, you will be having the people who are likely to adhere with the treatment. The presence of LAIs, long-acting injection versus an oral medication, may deter the patient from consenting to the trial. Again, if you are having two arms of trial in which one is being given injection, other is being given oral medication, and you ask the patient, do you consent for this arm? people are more likely to consent to the oral treatment arm rather than to the oral to the injection. The more frequent observations, and so again, so this is a false statement. The people are more likely to consent to the oral treatment, and that again minimizes the difference between the oral arm and the injection arm. And finally, the more frequent observations and assessments in the trial setting may improve treatment adherence. What do you think? True or false? It's again true. So what tends to happen in treatment trials is that, yes, I'm seeing Rizwan Taj hand raised. I think I'll reply to the questions at the end, otherwise it will become a bit confusing, but you can raise the question at the end. So the more frequent observations and assessments in the trial setting may improve the treatment adherence. So actually, that is what tends to happen. But when you have randomized the people in two arms, the patients are being observed more regularly, just like, say, for example, in case of the clozapine treatment. The patients are having blood test every month, and that helps to improve the treatment adherence. So similarly, if you are having the two arms in which one arm is the depot injection and other is the oral medication, and if you are frequently observing both arms, that will automatically increase the treatment adherence in oral treatment arm as well, and that will also help to minimize the difference between the two arms. So basically what I've tried to show in this slide is that it is the problem with the randomized controlled trial itself, the design itself, that tends to minimize the difference between the injection arm and between the oral arm, and therefore any difference between the long-acting injection and the medication may not show. So the long-acting injection may be effective, but the randomized controlled trial evidence may not show that. So it was just a question for you to understand the randomized controlled trials and the its role in improving the treatment adherence. Finally, we come to what we call digital technologies, and there are quite a number of technologies which have been used for improving the treatment adherence. They are simple things like electronic medication monitors, text messaging, smartphone applications, and they are, just to give you an example, what is happening in the digital technologies. Recently, FDA, this medication, I think it's not now recent, it's 2017, and I can name it, they approved a formulation of aripiprazole in which there is a sensor within the tablet itself. So when the person takes the medication and when the tablet is swallowed, it comes in contact with the stomach acids. The tablet resolves and the sensor comes out and it sends a signal. And that signal is then picked up by a monitor, which patient has, and that monitor then transmits the signal to the physician. So, and that is 100% guaranteed, because you know quite a lot of psychiatric patients, even they just would eat their tongue and spit out. And so apparently even just observing the patient may not mean that they have taken the medication. And this is a tablet which has been developed. I think it's not a very common use. It has been approved by the FDA. But I'm just trying to give you, a flavor of what's happening in terms of the improving the treatment adherence and the intervention. So this, and this has shown to be effective in improving the treatment adherence in a randomized controlled trial. There are other simple technologies. I will not go into the details. You can see the evidence from this. There are about 2 large controlled trials which showed that messaging patients regularly about taking the medication and reminding the patients for taking the medication does help them to take the medication regularly. And then increasingly now, there are smartphone applications. There are two smartphone applications, Focus and MedActive, which are being tested at the moment. And these apps are to help patients to remind about taking medication. Even, the medication, I think it's being used in dementia, that the medication pack itself has, a sensor which activates the phone, and that gives the patient a reminder that it's now time to take the medication. So there are quite a lot of smartphone apps being tested which can help the patient to improve the treatment adherence. So just to briefly summarize the evidence for the role of digital interventions in improving the treatment adherence, at the moment there are different technologies which are being tested, mostly in early stages of development. Simple technologies such as phone reminder and text messages work, they are effective, but unfortunately we still don't use them in our clinical practice. The interesting thing is evidence from the literature shows when you are talking about the digital technologies like text messages, reminders, like asking the patient. So there is a natural question that in people with schizophrenia, will these technologies be acceptable to the patient? Are these acceptable to the patient? Wouldn't the patients become more paranoid, say for example? Are they able to interact with the technologies? The answer is that most research evidence shows that people are able to interact and it does not increase their psychotic symptoms. So the newer digital technologies, if you ask me one simple conclusion of the evidence of the interventions, digital interventions to improve the treatment adherence in case of schizophrenia psychosis, one thing can be said simply is whether they are effective or not, but they are acceptable to the patients and they are feasible. So I think now I can summarize the evidence for overall interventions. So simply speaking, we have covered the psychosocial interventions, we have covered the pharmacological interventions, we have covered the digital interventions for improving the treatment adherence. And as you can see, it's a very broad field. So simply, I will not go into the detail, and people who know my work must be knowing about this. So these digital technologies, they are very expensive. Why not talk about simple things? And what we did, our group did, is I think those people who are working in Pakistan must be familiar with DOTS approach, directly observed therapy for TB control. And if you know that in the DOTS approach, a person actually observes the patient taking the medication. So it's a long story. It's about 11 years of my work, 10 years of my work at Lady Reading Hospital in Peshawar. So what we did is we actually translated the whole DOTS approach for schizophrenia. We called it STOPS, Supervised Treatment in Outpatients for Schizophrenia. And we did a randomized controlled trial, and this was published in British Journal of Psychiatry. And so basically what we showed that a supervised treatment approach where a family member is trained for actually patient ingesting and recording. We developed very simple tools for the patients, for the relatives to record, to take the medication they have taken, and then they would bring that to the treatment center, and then they will be given next batch of supply, just like it is done in the DOTS approach in TB. And what we showed that, and this was, I think at that time, this trial was done in 2007 and published in 2011. We showed that the STOPS approach was more effective in improving the positive and negative symptoms. If you can see, the left-hand graph showed the improvement in the positive and negative symptoms. And then the right-hand graph shows that as the symptoms improve, that also improves the global assessment of functioning. So basically, this STOPS approach has become a sort of low-cost intervention. And interestingly, I recently saw a couple of papers published in BMJ from Malaysia and China, where the STOPS approach is now being used for improving the treatment adherence. And now we are doing a large clinical trial of the STOPS approach. This trial was done in Lady Hospital and in a very, I think in 110 patients. Now we are doing a larger trial in whole of district Peshawar. And we are seeing whether it also works in the community. So basically the STOPS approach, you can say, is the poor man, intervention for improving the treatment adherence, and it tends to work effectively. I think sometimes I can give a full lecture about what is STOPS, how it can be used. But simply speaking, STOPS approach, what it does is it makes a family member responsible for supervising the patient treatment, ask them to be there. The patient takes the medication, the patient swallows the medication, and then note that in a simple sheet. And it's not just that they actually observe the medication, just record it. They are also educated about the medication, what are side effects, how to overcome. So it's a whole approach. So finally, I will speak now. We have talked about the interventions for improving the treatment adherence in schizophrenia. How we can put them in clinical practice. I think one thing which I would ask you, it's treatment adherence is just like a risk assessment for suicide. When you see a suicidal patient in your clinical practice day in and day out, you do a risk assessment, whether the patient has a previous history of deliberate self-harm, that increases risk. Similarly, I would suggest, and that is the evidence from the literature as well, that when you are seeing a patient with schizophrenia in day-to-day clinical practice, when I see a patient, at the same time, I make an assessment whether the patient is likely to adhere with the patient medication or not. And if the patient are likely not to adhere to the medication, then you need to take an aggressive approach for improving the treatment adherence, even though the patient is saying that they are going to adhere. So simply speaking, I classify the risk factors for treatment non-adherence into 4 groups. One is called patient-related, like poor insight, prior history of non-adherence. This is one of the strongest risk factors, just like the prior history of deliberate self-harm increases your risk of suicide. Beliefs about medication. If the patient has the belief that treatment is addictive, it's a sign of personal weakness, they are not likely to take the medication. Substance abuse, cognitive impairment, if they have poor memory. Then there are society-related factors. If there's too much stigma, which you can assess when the patient are talking and the family is talking about the illness. Stigma caused by the medication. If you see, I will ask you to look at these factors, and just like the risk factors for cardiovascular disease, when you talk to a cardiologist about the risk factor for the heart disease, they would call them modifiable risk factors and non-modifiable risk factors. So say, for example, your genetic history is non-modifiable risk factor, but your cholesterol is a modifiable risk factor. Similarly, for medication adherence, I call things like poor insight will be very difficult to modify. But there are factors like belief about medication, substance abuse, cognitive impairment. These are what I call modifiable risk factors. And when you assess the patient, you assess these factors and see how many factors you can modify. The other group of risk factors is like environment, relationship related, lack of family social support, problems with therapeutic alliance, practical problems, side effects, lack of efficacy, continued symptoms, and complex treatment regime and pill burden. So as a physician, I would say every time you see a person with schizophrenia, whether it is a follow-up appointment, whether it is a new assessment, along with because frankly speaking, at the end of the day, how much evidence, how much effective medication you have. Say, for example, you have a golden bullet which improves every symptoms of schizophrenia. If the patient doesn't take, it doesn't work. Simple as that. And so you have to make an assessment of whether the patient is going to take the medication or not. And I'm going back to, so I would suggest for every time a person visits, you make a risk assessment, you do an assessment of whether the person is going to take the medication or not, make a risk assessment, and then see what are, these are about, I think, 12 risk factors: patient-related, society-related, environment-related, and then the treatment-related. So what are the factors which you can modify? Can you improve the side effects? Can you improve the pill burden? Can you reduce the number of medication? Can you involve a family member? So once you have made a risk assessment, you work on based on that risk. And then you also assess the medication regularly. I think at every follow-up appointment for every patient, we should be regularly asking, because I was listening a lecture some time back from a forensic psychiatrist who did one of the largest audit of the people with schizophrenia who either killed themselves or killed someone else. You know, it's one of the largest studies done in UK, where they do a national audit of all the patients with schizophrenia who killed themselves, suicide or homicide. And he mentioned one very interesting thing. He said that if you ask me one common thing in the audit of these people who had suicide or homicide, one common thing was the number of medication which was discovered, the amount of medication which was discovered in these patients' cupboards after the event. So one common thing he mentioned is that after all these homicide and suicide events, there were piles of medication lying in these people's cupboard, and they were telling their physicians, they were telling their psychiatrists that they are taking the medication regularly. So I think we have to religiously ask these questions. Have you missed any medications? How are you taking your medication? Have you ever forgotten to take your medication? Are you experiencing any adverse drug or reactions? How are you feeling since you last started medication? These 4 questions, 5 questions will give you more information about the treatment adherence than anything else. So it's not just asking about the question, just asking whether you are taking the medication. Also important to ask how they feel about the medication. So, and once you have asked about the treatment adherence, you need to inquire what will be the desirable outcome. You don't need always to talk. I think one thing we have to understand is that we don't always ask about it's not always good to give the lecture to the patient that the medication is useful. You have to inquire what patient likes to do, what is the patient's desirable outcome, and then work around that. As I gave example previously, say for example, patient doesn't want to take the medication, but he still wants to go out. So, okay, so it's your anxiety which is preventing you going out. And this anxiety will be helped by this medication in this way. So these are the strategies to enhance the medication. I will not, so anticipate the barriers to medication adherence and discuss the solutions from the very beginning. Involve the family members and friends if patient agrees. Provide oral and written instructions both. Use of practical medication reminders, simple things like us advising them to set up the mobile reminders or calendars. Pairing the treatment to fit the patient lifestyle and developing a multi-component approach, both cognitive and behavior. So in conclusion, I would say one of the things which I always say, with good therapeutic relationship, you know, when you read the psychiatric textbooks, they always stress the good therapeutic relationship, and that is always important. But I say With good therapeutic relationship, patient may engage with the therapist, but not with the medication. It's very important. So the patient may be coming very religiously to you, coming to you, listening to you, and saying, Dr. Saab, how good you are and how smart you are. But whether they are taking the medication or not, this is a different thing. So with a good therapeutic relationship, the patient may engage with the therapist, but not with the medication. And for engaging with the medication, you have to consciously think about medication taking behaviors. What are the risk factors and what are the interventions you can improve? And you need to access the adherence, engage the patient in medication taking behavior, use intensive focused approaches. Long-acting injections are helpful, but you should not only realize on the long-acting injections. The important thing to realize is that the long-acting injections are helpful in people who lack insight, who are not taking the medication, but they are not very helpful in those people who have good insight, but they are not taking the medication for some other reason. You need to use the most effective treatment strategies alone or in combination. Yes, this is another thing which I always stress. Trying to achieve the complete remission from the day one. What we tend to think is, and let me elaborate on this point, what we tend to see in our clinical practice is that people don't take the medication and then they tend to relapse. What we don't realize is if the medication doesn't work effectively, or if you do not use a very effective medication in a very effective way from the very beginning, and the patient is not able to have the complete remission of the symptoms, the presence of residual symptoms in themselves then interfere with the treatment adherence. So there are a sort of a, I would say, vicious cycle, because symptoms are not fully improved. Therefore, the adherence, they interfere with the treatment adherence, and because they are not taking the medication, that makes their symptoms worse. So use the most effective treatment strategies alone or in combination from the very beginning to achieve the complete remission. So that's all I have to say. Thank you very much. I'm on Twitter. You can follow me, and if there are any queries, you can send them by message. I will try to answer them. These are the two useful articles which will give you the further evidence, and they will also provide you with the references, I think. So, so that is all I have to say. Thank you very much.
Thank you, Professor Saeed, for such a nice presentation. Here, I would like to introduce a very distinguished guest who shortly honored us. He is Professor Afzal Javed, a UK-based consultant psychiatrist. He is the president-elect World Psychiatric Association. Professor Afzal was also given the title of Distinguished Global Psychiatrist by Pakistan Psychiatrist Society. Professor Afzal, kindly give your comments and words of thanks for the session. Thank you.
Well, thank you very much, and Assalamu alaikum. Thank you, Saeed, for such a brilliant talk. It's always a pleasure to listen to you whenever there is an opportunity. And I'm glad that you are offering your services to our Pakistani colleagues. It's very important in many ways. And I must say that credit goes to Pakistan Psychiatric Society, its members, and especially its officers like Professor Akbal Afridi, Professor Imtiaz Dogar, Professor Mia, because this is what Pakistan Psychiatric Society should do. And I'm really pleased that PPS is approaching those Pakistani psychiatrists like Saeed Farooq, who are really making an international visibility and bringing back home some of the findings, some of the work which is initiated by people like him is really a blessing for all of us. And I think I was just speaking to a few people last week that hopefully the COVID-19 will be over, but the organization of webinars is not going to leave us. And I think this is a sort of a wonderful idea for our member societies like Pakistan Psychiatric Society and many other societies, that they are using this technology, especially for updating the information, skills, and knowledge for our postgraduate students. And I'm sure this will continue, and during the coming months, coming years, probably we may be able to use this particular facility in a more effective way. And I would also like to extend all my support to Pakistan Psychiatric Society, Professor Afridi, Professor Imtiaz Dogar, who is the incoming president, that if you want in future, I can always contact some of the other non-Pakistani experts who may be able to agree to join these educational programs which are being started and which are being propagated from the platform of PPS. Thank you very much. And thank you, Saeed, once again. It's really a sort of so nice of you for sharing your excellent work with all of us.
Thank you, Professor Javed, for the very kind words. And actually, yes, you're absolutely right. I'm honored by the PPS, and this, the present PPS cabinet has done really well for improving the education and training in Pakistan and psychiatry. It's a wonderful bunch of people, and I'm really proud of them. Thank you.
Thank you, Professor Abdul Javed. Here, I would like to request Professor Dr. Mohammad Iqbal Afridi. He is the President of Pakistan Psychiatric Society, to kindly present the certificate of appreciation digitally to Professor Saeed.
Before that, so before that, let me formally thank you, Professor Saeed Farooq, for sparing time, especially on Sunday. And I'm also thankful to Professor Afzal Javed for gracing this event. He's a distinguished global psychiatrist, and he's, although very busy, having busy schedule, but spare time for this program. And I'm also thankful to the postgraduate participant, although it looks like 100, but I think it's more, because in my department, many people are in just from one link, that is Manisha Kumari. So that means and I know that there are Professor Mukhtar will bear me that they are also having people in his department. So on Sunday, if people can spare time for the teaching and training, I think this is a very healthy sign. And
exactly.
Let me, and I can see many distinguished faces like Professor Rizwan Daj, Professor Dogar, Professor Mukhtar, and so many others are there. So let me now formally give the digital certification to Professor Saeed Farooq. हमारी ये भी एक रिवायत है, वो लगा दें जरा इसको और तालियां भी बजाएं. कहाँ सर्टिफिकेट नीचे?
Thank you, sir. Thank you for.
अच्छा, Professor Mukhtar, something? जब तक ये सर्टिफिकेट निकालें डिजिटल.
And thank you very much. Thank you very much, Professor Saeed Farooq. I mean, I don't have the second words. He's my mentor, my lifetime mentor. So I mean, I'm very thankful that he spared time, and thank you very much, sir.
Let me also appreciate the participation of our very distinguished Professor Muaddat Rana, who was the dean, and he's the shining star of psychiatry, the star of psychiatry. I will request him to comment a few words.
It's good that I didn't know Muaddat Sahab is already there. Otherwise, I would be feeling panicky from the very start.
अच्छा, मेरे ख्याल है वो सुनाएंगे. वो अहिरा शबीर के नाम से उनका उसको अनम्यूट कर दें. हिरा शबीर के नाम से वो इंटर है। जिस तरह मैं यहाँ से मनीषा कुमारी हमारी जो है उसके नाम से इंटर, वो लोग सोच रहे होंगे कि ये क्या हो रहा है, लेकिन हमने पूरा एलईडी लगाई है, उस पर सब देख रहे हैं और हमारा वार्ड खुला हुआ है। जी जी।
अच्छा,
तो मोहतरम राना की जो है वो शायद उसके नाम से है। अच्छा, हिरा के नाम से हमारी
वो अपने आप को म्यूट कर सकते हैं मोहतरम राना साहब,
वो खुद अनम्यूट कर सकते हैं, नहीं तो अच्छा प्रोफेसर डोगर, वुड यू लाइक टू से समथिंग?
Hello, Assalamu alaikum.
Walaikum assalam.
Saeed, what a pleasure to see you on a Sunday afternoon. It's an absolute treat. And to also have Professor Abdul Javed in the frame, absolute pleasure. Both of you remind me of those wonderful sons of Pakistan who have gone abroad but have never reported themselves. They've continued to stay connected with all of us back home, and they've never forgotten their roots. Thank you very much for making us proud internationally, but also making us feel connected to both of you. It's a wonderful feeling, and to also let our trainees feel that they have chosen a path that can lead to such excellence in their respective professions. It's inspirational figures like both of you who makes life worth living, and role models for the future psychiatrists of Pakistan. It was equally wonderful listening to you, Saeed, on your favorite topic. I have tried to practice what you have taught all my life in my practice, and I found this strategy very practical, very useful, very sensible, and yet so simple. Exactly the way probably you are as a person.
Thank you. Thank you.
So, and I must also congratulate Professor Iqbal Afridi and his wonderful team for making this innovative initiative possible, in which people from around the world can contribute towards Pakistani psychiatrists in general and postgraduate trainees maximally, and inspire them. Thank you very much, Iqbal and Mukhtar and all the other leaders, Imtiaz Dogar, for making it all possible. Thank you very much for asking me to comment.
Thank you very much, sir. Now I'll request Dogar to say a few words. Mr. Dogar. If he's not here, Professor Asad is requested to say a few words.
Assalamu alaikum. I think it's always a pleasure to hear from a great teacher. So Professor Saeed Farooq is a great teacher. I still remember when he took my fellowship exam, and from that day till on, I've always learned from him. And I think we're also very pleasured and honored to have Professor Abdul Javed, I think another icon from Pakistani psychiatry, on board with us. And I think this lecture is very, very, as I wrote down, very innovative and informative, because these residents who are in this group, about 250 of them, some may not have joined, but it's actually an insight to them that how bright stars from Pakistani psychiatry we have. And I think they have a better exposure now with all those bright stars, whether they're in and outside of Pakistan. And when they listen to these lectures, I think I give a lot of credit to Professor Iqbal Afridi and obviously the team with the PPS. I'm part of it. One more evening, we decided to go on to this method of e-learning. I think the next morning, Professor Iqbal Afridi had initiated it. And I think Professor Mukhtar made the group. So the best part is that how quick we were able to go into execution. And I think that's the beauty of this whole program. And as Professor Abdul Javed said, we're not going to stop after COVID. So inshallah, I hope we keep on having it and we have more and more speakers. Again, very, very happy to see Professor Saeed Farooq, and very, very happy to listen to you, sir. Thank you.
Thank you. Thank you very much, Asad. Very always trying to.
But due to time constraint, हम उज़ैर साहब से रिक्वेस्ट करेंगे कि ये कीमती सवालों को जमा करना है। फिर हम सईद फारूक साहब से रिक्वेस्ट करेंगे कि ये सवाल जो है इनके जो है ना फिर वो जवाब दे दें, लिख के जो है ना वो उनको भिजवा देंगे, क्योंकि टाइम हमारा अभी ख़त्म होगा। उसके बाद में हम कोविड स्टडी के मुतालिक मीटिंग होगी। तो मैं आप सबका तहे दिल से शुक्रगुजार हूँ कि आप लोग संडे के दिन तशरीफ़ लाए, और इस दुआ के साथ क्या अल्लाह आप सबको हम सब हिफ्ज़ो अमान में रखे, हमारे मुल्कों को, पाकिस्तान और दीगर ममालिक ग्लोबल जो कंट्रीज हैं उनको जो है अल्लाह तहफ़्फ़ुज़ दे, और न सिर्फ इस वबा से बल्कि दीगर अमराज से भी हमें तहफ़्फ़ुज़ दे। वसल्लल्लाहु तआला अला खैर खल्क़ी अजमईन बिरहमतिका या अरहमर राहिमीन।
Thank you. Jazakallah, Iqbal sir.
At the end,
Thank
we are
you
very
all.
to our chairman, Chaudhry Suhail Saab, Dr. Asad, our project director. Then we are very thankful to our course director, Professor Altaf Alam Saab, Dr. Zishan Saab, Dr. Bushra Saiba, Dr. Amna Askar, my administrator, Mrs. Kiran Amir, our IT support, Haris and Sulman. Thank you all till next time. Allah Hafiz.
Thank you. Khuda Hafiz.
All of you, your team, and the ECO people, Pakistan, Parsa, and all the members there, they are really supportive, and wish you all the best.
Thank you
very much.